Good morning, everyone. Can we start with the word of prayer, please, if you can stand up. Heavenly Father, we thank you once again for bringing us together on this Thursday morning with a purpose that we'll learn something new, we'll put it into practice in our daily healthcare areas for the betterment of the patients, those who come to us. We ask for your blessings on the speaker and open our hearts and minds to absorb so that we can function better and deliver the care which our patients require in critical times. Thereby we bring glory to your kingdom and the institution will prosper in the days to come. In Jesus' precious name we ask. Amen.
Good morning, everyone. Today's quest is going to be a very, very relevant topic. Everyone may think that this is a very simple thing, but this is very relevant. To just give you a background, one of our former head of the department was admitted here for some reason. Went home, she was on Atrapid and Lantus, both vial. So Atrapid should be taken in, it's a 40 IU per ml preparation Atrapid, and Lantus is 100 IU per ml preparation. But when at home, she took Lantus using 40 unit insulin syringe and came here at middle of the night with severe hypoglycemia. So insulin prescription errors are very, very common, and it is estimated that nearly 0.5 million adverse events, even deaths are happening all over the world because of the simple insulin prescription errors. And fortunately, we have a very good insulin prescription chart, which is it is available here, which is grossly underutilized. So I hope this is going to be a big awareness session, and I hope after this quest, we in our institution we can significantly reduce insulin prescription errors and also spread this message all over, everywhere, to our colleagues and to our friends and everywhere. And over to you, Dr. Anulekha, madam.
Good morning. I must admit that I'm actually speaker trapped by Dr. E.T. Arun. So I have my own trepidations. I will try to do my best. So like Dr. Arun said, it's a very simple topic. So I will start with the story that actually happened, very similar to what Dr. Arun shared. So this is a patient named Sarah. This story is slightly changed, but actually happened in our ward. She is 58 years old, diabetic patient for the past 14 years. She had been on insulin, and taking insulin had become very regular routine for her. So while she was traveling for a wedding in the family, they all had to go somewhere and stay in a hotel. So she took her insulin, she took her glucometer, everything was in place, but just that she forgot to pack the syringe. So she had been in the Middle East for a long time and had been in Kerala now for past 2 or 3 years. So she had been using the syringes and insulin from there and been buying that from the same pharmacy as always. But a relative said that no problem. He went and got a syringe for her from a local pharmacy, and she took her usual dose of insulin. So about 5-6 hours later, after her evening dose, she felt very shaky, confused, and she was drenched in sweat, and her blood glucose levels were very low. Now, when we speak about international units, we should understand that, particularly for all the students and juniors here, I'm sure all our faculty are very clear about it. So the IU actually describes a concentration. It is not an actual amount. And the syringe should match the international unit or the concentration of the insulin. So if an insulin is packed as 40 IU per ml, it means that 1 ml of the liquid actually contains 40 international units of insulin. Similarly, 100 IU per ml would mean that 1 ml contains 100 units. So if you look at the absolute amount, it may not be same. It will be different. It is like I tell my patients that you take 1 liter of water in 2 buckets, and into one you put 40 kg sugar and mix it, and in the second one you put 100 kilograms of sugar and mix it. The concentration is different and the taste will be different. So you cannot equate 1 ml of this to 1 ml of that. So this is this 40 international units per ml is so dated. It is an ancient old preparation, and only very few countries continue to have it. But somehow India, we have more of 40 IU per ml, and when our patient says they are taking insulin and in an insulin syringe, they really mean that it is a 40 IU per ml syringe. So 100 IU per ml is a global standard. That doesn't mean that there aren't any other concentrations. We also have 200 IU per ml that mainly comes in pen devices, and also even 500 IU per ml. So those patients who are taking very high doses of insulin, they might require such high concentrations. Now this is the picture of the syringes. Now you know that 100 IU syringes are always orange capped. The bottom and the top is orange in color, whereas the 40 IU is red in color. Now tell me, red and orange, are they very different? Sometimes for old people, if you put it together, you might realize a difference. But seeing it just as one packet, or seeing only the 100 IU or the 40 IU, sometimes it is difficult for people to say whether it is red or orange. So I wish it was either yellow and blue or some other differently distinguishable colors. So now it is this way. So sometimes it is very difficult, and we have to really ask our patients. Sometimes it is good to tell our patients to bring the syringe along with them. So this is a 40 IU per ml insulin, and again we have so many different colors and preparations, it is sometimes very difficult. So when we ask our patients, is your insulin 40 IU per ml, they will say no, it is 30 by 70. So there is the mixing of insulin is different, concentration is different. So there are various types of insulin. Sometimes it can be very confusing, but this is where you should look at 40 units per ml or 100 units per ml. So this is the orange topped 100 IU syringe. And if you take a syringe which is 100 IU per ml and you take the insulin which is 40 IU per ml, it is not calibrated for each other, and you can get into gross errors. Now, I told you about the colors, and what happened with this lady is that the design is nearly identical. Both the syringes are, the patient will tell you, yes doctor, I take it through that thin syringe. So they can't really identify that. Sometimes patient can be tired in the dim light and the small print, and we are very well known for not reading the small print, isn't it? Okay, so this is the barrels. So if you look at it, you can see that the same 1 ml barrel is divided into 40 units in 40 IU and 100 units in 100 IU. So when you do the math, so 100 units which is in the 100 IU insulin, if you take it in a 40 divisions, what will happen to each division? Instead of it being 1 unit, in a 40 IU syringe, it becomes 2.5 units. That is 2.5 times. It happens the other way. If you take a lower concentration of insulin in a higher numbered syringe, it will be divided by 2.5. So that is the difference. So I'll make it clear to you. So Sarah's helper drew the plunger to the 10th mark printed on a 40 IU syringe. But the syringe was actually filled with her own insulin, which was 100 units per ml. Now if you take the 40 IU syringe, it has got 40 units. So 10 units is 1/4 of it, which is 0.25 ml or quarter an ml. Now that insulin actually contains 100 units. 100 units in the quarter ml of 100 IU will be actually 25 units. So the patient is seeing insulin drawn to the 10th mark, but actually what the patient receives is 25 units of insulin, which is 2.5 times more. That can be really dangerous for the patient. So that is what happened to this patient. It actually happened in our ward, and when we went and checked the patient's syringe, we realized that she had been using a 40 IU syringe along with 100 IU insulin. So this is what happened, and she developed hypoglycemia, which is a medical emergency. Sometimes this patient was inside the hospital, we could identify and treat her. But sometimes if it happens in the night, the patient will not live to tell you the story. we might think that it is, what will we say? The patient died in the night. So what will we say? Patient had a heart attack. So the verbal autopsy says that it is a heart attack. But actually what happened was hypoglycemia. So it is very, very, very important. And when we really play with lives, it is very important that we check all these. So the opposite of it is underdosing. So when you take, I earlier said that if you take a lower concentration insulin in a higher concentration syringe, you will end up underdosing. Again, if you intend to take 25 units, you will end up taking only 10 units. So in the emergency room, the treating physician identified this, and the mismatch was found, and the fix was immediate. The correct syringe and the correct insulin was resupplied, and everything was well. Now the important thing is to always match the syringe concentration directly to the insulin vial concentration, and every time we need to check that. Even when our patients say they are on Mixtard or they are on Act Rapid, always find out what type of insulin they are taking. So if the patient finds it difficult to carry the insulin in a cold chain maintained manner, you can always ask them to take a picture of their insulin and vial and the syringe whenever they come to visit us in the OPD. Alright, so read the vial, check the cap color and verify the unit marks. Now, I need to also tell you that in addition to the common mistakes, we also have the problem of our patients being very frugal. So, a patient finds that the insulin pen cartridge is very expensive and the vial is quite cheap. So, this frugal-minded Malayali population, what will they do? They'll ask the shopkeeper, and the shopkeeper is even more happy to help this parsimonious nature. So that they will say, you bring your empty cartridge, I will fill it with the cheaper insulin. So then the patient, you can see in the picture, an elderly man is sitting with the shopkeeper. What he's trying to do is drawing the insulin from the vial and injecting it back into the cartridge. So we have any number of stories of how many types of insulin errors occur. So when we look at it, the patient brings the insulin and the cartridge along, and the cartridge is actually, it is written 100 IU per ml. So when you probe a little bit deeper, then we realize that this patient had been refilling the insulin cartridge or the pen fill. So that is also a possibility. So we should be mindful of all these things happening around us. So protecting our patients and more importantly, protecting ourselves from legalities. So that is why we designed this BCMCH, GRBS and insulin order sheet, which is being circulated there. I will just show. So can you see this? So this chart was actually made during the years. We spent almost 1.5 to 2 years designing this chart, and a lot of people put in their effort, primarily my diabetes educators, Sister Deepa Lakshmi and Sister Rishmi were the main people who helped. Dr. E.T. Arun was also instrumental in making this. Then all my colleagues in the Department of Medicine, S.K. Matthew sir, Jen C, Joseph John sir, all of them, and even the ICU team, they all gave their little bit of inputs, and we finally designed this. So the first sheet, if you have it in your hand, you can see that it is an area to record the glucometer RBS values. Below that you have a space for stat orders. So next is the main part, that is the order sheet. Now I know that we have an order sheet common, we have an order sheet for antibiotics, now we have an order sheet for insulin. Sometimes it can be quite overwhelming, but we don't need to write it in the orders, but we can just use this. So I will explain how to do this properly. This insulin doctor's order sheet is on the left hand side, and on the right hand side to the corresponding columns we have the nurse's chart where they can record how they have given the insulin. I'll explain that. And the last page is actually an insulin infusion protocol sheet. So everything about insulin comes into this very same chart. So it becomes very easy. Okay. So this is the doctor's order sheet. I'll just concentrate on this. Now we can see that there is a first column is for date and time of order. There is ample space. So we cannot say that we didn't have enough space to write the date. There's plenty of space. We can write the date explicitly. Then there is a place for that's the date and time of order. There's a place for the name of insulin. You can write clearly the brand name or the generic name of the insulin. Then there's a place for specifying whether it is 40 IU per ml or 100 IU per ml. Is it a pen or a syringe? And how is it to be taken? Most of the insulin, which is regular human insulin, is to be taken 30 minutes prior to the meal. We know the reason. Insulin forms a hexamer within the subcut tissue, and it takes about 30 minutes for it to dissociate to monomers. So that is why it has to be taken 30 minutes prior to the meal, provided it is a human insulin. Now in our ward, sometimes the staff tells the patient, we've given the insulin, now you can eat. It is not so. We have to look at the insulin. That is why the order has to be explicit. Unless we specify, the staff will not know how to tell the patient. So we must write either half an hour before meals or 30 minutes before meals. And for all analog insulin, it can be taken with the meal, just before or just after. All right. So dose and frequency can be written here. It can be written two different ways. I'll show you examples. And again, there is ample space for clearly writing one's name and putting your signature. Now you might wonder, what are the other columns for? So this, what I just described, is the first insulin order you are going to write, the first day. If you do not intend to make any changes, it remains like that, and the staff will follow that order. In case you saw the next day's glucose readings, you found that the insulin is not sufficient, or if the patient had a hypoglycemia, you want to change the order. So the next columns are for change in dose, if any. If you do have a change, you have space to record the date and the time and new dose and signature. So you can see that there are ample space for 5 orders. 5 times you can change the same insulin using the same block. You don't have to cut the previous order. The insulin and the type, all those will remain the same. Unless you're going to change that insulin, then you can cross it out and go to the next block. So this is the place for changed date, changed time, the new dose and signature. So this actually saves the staff nurses. So sometimes what we do is, we come for rounds after the morning dose is given. Then you come and change the order. Now, when you audit the chart later, you have an insulin order on 29th of July. It says morning dose is 12 units. But actually the staff has followed the previous day's 6 a.m. dose. So how do you know when it was changed? So change that day, that time is very important. You would have gone for rounds at 9:30 a.m. and changed it at 9:30. The 6 a.m. dose is already gone. So we can clearly know what dose has gone in on which day. So that is very important to document the time, and again new dose and signature. So the goal is for one clear order, and it should be the standard for everyone in our institution. So this is an example of how it is written. You can see that the date and time is written very clearly. Name of insulin, human actrapid, 100 IU per ml, using a pen device. The relation to food is half an hour before meals. In the first column it is written 10 units with breakfast, lunch and dinner. So that is one way of writing your order if your units remain the same. And there is name and signature. The next day you came for rounds and you realized that the post-breakfast sugars are not controlled. Post-lunch is also not controlled. But the patient had a hypoglycemia post-dinner. You want to adjust the dose. So that is the next day, that is 29/7. You came for rounds at 9:30. You have written the order. So now I know that at 6 a.m. on 29th, the order that would have gone is the order on the 28th. So from 9:30 onwards, the new order is going to be carried out. So next day when I look at the post-breakfast sugar, I should not go and increase the 12 to 14 because the patient received actually 10 units on 28th. So that makes sense because this, we need not blame the staff for not giving insulin because the time is very clearly written there. So that is about the doctor's orders. And if you do have a change on the 30th, then you can utilize the next column. The next one, and so on. So there is opportunity to change without cutting up to 5 days. Now, if you have another insulin along with it, now this is a short-acting insulin. If you have another insulin, you can write it in the next block. If there is a glargine insulin, you can write it in the next block. Now, corresponding to the doctor's orders, on the next page, left-hand side is doctor's orders, right-hand side is the nurse's documentation chart. So the staff can clearly document like this. The date is there, name of insulin is there, time can be written, and the dose of insulin, and they can clearly sign their name. Now, if there is a change of a stat order, there is an additional space there to write the time of a stat order. That's why there are 4 rows. Again, correspondingly, there are opportunity to write 5 different days. The order for 5 different days is also given. So that is about the BCMCH insulin chart, and this is what we wanted to introduce. Even though MS Office and System Mini had really approved it in 2024, you can see that this form has come in circulation from 2024. We find that it is being underutilized. That is one of the reasons why we decided to have this quest. And if you have any comments on any difficulty in this order sheet, you can bring to the notice, and in the next amendment we could do that. So thank you for your patient listening.
Thank you, madam, and thank you very much. And it is now, I know there is a lot of discussions needs to happen. We have remaining time. So, any comments?
Actually, I noticed that regarding a great mismatch in the insulin initiations and the dosing, and actually that patient goes into the hypoglycemia and hyperglycemia. So that appropriate documentation will definitely help in the better management of the patient outcome. Otherwise, patient, once they develop hypoglycemia, it will be lethal to the patient, because sudden hypoglycemia produces a counter hormone release and a sudden ventricular arrhythmias and death. So that we can prevent from that, even though it is seems to be very simple, but we have to very carefully up titrate and down titrate the dosing and meticulously manage our patient for a better outcome.
Thank you, sir.
Thank you.
Dr. Anulekha, thank you so much for that.
Thank you, sir.
I must honestly tell you that in my mind there's still a lot of confusion. That's because of my age. But I'm requesting you, just like Noblezak is doing in Kochi, can you become the hub here to keep on both in terms of social media, because a lot of misunderstanding.
I'm poor at it, sir.
So we can then find a team that can do it.
We have Dr. Arun.
I know, they are doing a good job. But what happens is when it comes from a hospital, there is much more awareness. And a lot of people, we get about 4,000, 5,000 people. The footfalls are about 5,000 every day. And we know that 30% of our people are diabetics. So is there something more that we can do to this awareness, especially with the syringes and all, is not there at all. And then we've also come to a stage where people are writing or calling saying, can you please send these medicines here, and all the rest of it. There's going to be a lot of problems.
In our TV channel, in a few years back, mentioning these fallacies, recorded and broadcasted in the TV. That may be there in the with the particular team. Just this I just demonstrated in video, and it is an half-an-hour program.
To add on, so we have something called as pen type also. So each brand insulin cartridge should be used with the corresponding brand insulin pen also. So everyone should be aware about the cartridge name and the brand and that particular brand's pen. Otherwise there will be incompatibility. So that should be also kept. And under the pen, you can prescribe the name of the pen. For example, if it is a Novo Rapid, it is from Novo Nordisk, you have to write Novo pen. So if you are using Landis cartridge, you have to use All-Star pen. Similarly, pen name also should be the same. Because if you use other companies' pen, the delivered dose may not be always same. And over to you, Mini Madam, for comments.
Thank you very much, ma'am, for this very enlightening talk. I missed a bit of it because I was attending a funeral downstairs of one of my staff. Yes. It is very important that the orders are written on time, legibly, and it is understood. Also, it's a high alert medication. So the policy regarding the high alert medication has to be followed. The verbal orders that is given can be very confusing. So it is better if we try and minimize the verbal orders and it is documented on time. And cross-checking for the nurses especially. Always it's important that one person doesn't. That's all part of the medication administration policy. So it has to be signed, countersigned after actually checking the medication. The right site and the right dose is also very important. So another point I would like to suggest at this time is it's always right to, it's always better to go and inspect the site of injection to see if there is a rotation of site, especially for patients who are chronically diabetic. So that is also very important. And this chart was not done. The evolution of this chart is quite a long story. There was a lot of, they formed. Anulekha ma'am did it up with her group, and then we did a pilot study on it. It went on for a while. It just did not evolve. So even now, if you feel that there is some kind of a suggestion that needs and it can needs any modification, it can be brought up. So thank you very much.
Thank you, ma'am.
Because it was very easy 25 years ago to manage insulin. We only had Actrapid and Lente, and it is much easier. But currently the problem we have is there are plethora of brands and plethora of insulins which are available. It's so extremely confusing. I remember once Dr. Rennie Napoleon gave us a call saying we need to have all the interns oriented to how to use insulin. Currently all the interns, MBBS interns, are rotated in our department for 1 week each, where the primary role is to educate them about the type of insulin, and our nurse educators spend a lot of time and they shadow us. I think it is making a small dent in the understanding of insulin and how to order, but I think we still have a long way to go. I know that the nurses in their induction get a class by the nurse educators, but I still feel there's a lot of confusion in this area. So I think a better educational system by which everybody is signed off before you prescribe insulin. I think some sort of a mechanism we need to evolve so that we reduce the number of errors. And Dr. Anulekha and our team had done a study on the common errors in insulin administration. We found there were numerous errors each patient. One patient used to do more than one error. And most of the time we didn't have to increase the dose of insulin when we treated them. We just had to correct the error and their sugars would become controlled. Even PhD people, patients, people who are very well educated would be sometime giving the insulin subcutaneous. Not instead of subcut, it will be intradermal, and they will not take the insulin. And plethora of errors. We couldn't publish it because there's just so many errors and we had a small sample size. So hopefully we want to look at this particular thing in more detail, but we really invite suggestions and comments from the rest of you who have worked in different setups. And thank you, Dr. Anulekha, for highlighting very practical issue which all of us are facing every day. Thank you.
Educators are there, but they are underused by the doctors, and then you direct them to the diabetic educators. They will solve the most of the problems, and the dose fixing also they can do it very well. That is a thing which you should make, because a large number of the patients are diabetic with the kidney disease, diabetic with heart disease, so they need all type of education and send to the educators.
Thank you. I hope if you are using this chart, a good amount of insulin prescription errors inside the hospitals can be brought down. Unfortunately, the use is very, very less. Everyone is using the conventional chart. Just like how we have an antibiotic prescription chart where it is only allowed to prescribe antibiotic in the antibiotic prescription chart, the insulin should be only prescribed in this chart. Am I right? Yes. So outpatient department, for example, I'm going to write a human mix chart. So the prescription should be human mix chart, 30/70, 40 IU per ml preparation, 15/010 using 40 unit insulin syringe. The vial concentration and syringe type should be always prescribed. And if you are prescribing a pen preparation, the cartridge name and the pen name should be always prescribed. Otherwise, the prescription is incomplete. So OPD, it is an EMR based. No, that is not. So any comments?
EMR really helps us a lot, so we encourage everyone not to use the outpatient written prescription, but to use EMR. It actually saves us because there is one more level of protection, because the pharmacist always calls me. I'm ever so grateful to the pharmacy, because if I make a mistake, they will always call. Whether there is a double prescription, whether there is an unintended once a month becomes once a day, they always call, and I'm really grateful to our pharmacy. So if we give an EMR prescription, that actually saves us, because anyone can make a mistake. Nobody is exempt from that, and the likelihood of making an error is much lesser with an EMR prescription. Thank you.
Good morning, everyone. We just have 5 minutes. We just need 5 minutes of your time. We have a very exciting news from our pharmacy team that is to be presented by Viju sir. I kindly invite Viju sir to the stage.
Viju, thank you so much for that. I think all of us have to remember that when we work in the service sector, when we work in the non-corporate sector, the two areas from where we get income without doing anything wrong is one from pharmacy, the other from the labs. So essentially, if we do our work well, and if our patients buy drugs from here, and if they have their tests done here, we don't have to do anything. And we must make sure that it is done so well, and the Riju and team are making sure that the results are accurate, and we make sure that the opening of one pharmacy on the second floor has really helped. And if our service is good enough, so in the service sector, in the mission sector, just remember these are the two areas from where we get income, and then we can, with that, we'll be able to help a lot of patients. So to Biju and his whole team, congratulations and thank you very much.
We would like to have a small cake cutting for the team. For the representatives of each of the pharmacies are also here. So we kindly request you to be there. we invite the pharmacy team and the representatives of each of the pharmacy, our associate directors, George Andy sir, Rosie ma'am. Mini ma'am, Mini ma'am. We would like to give a token of appreciation to Vijay sir.